Okay, let's begin our session this morning with Ummul Kitab Al-Fatihah. Okay, first before we begin, I would like to your group. This is the first time having long case session with me, kan? Ke benar? First time. Okay, alright. Firstly, I would like to apologize. This is not an ideal punya situation lah. Ideally, doing face-to-face long case discussion will be much better. But well, we are not working on a normal ideal situation here because of COVID and so on and so forth. But we'll try and do the best that we can to actually still deliver proper medical education for you guys. Okay, all right. This is the format that's going to be. One of your colleagues already prepared a case to be discussed, is it? Again, okay. So if you have long cases with me, this is going to be the format. Year 3 ke, year 5 ke, this is what I expect from you. Okay, what's going to happen is one of your colleagues will present the case. So everything about the case, like introduction, HOPI, chief complaint, HOPI, systemic review, blah blah blah, apa semua, physical examination, and then summary of the patient. And then you stop there. And then from then on, what I want from every one of you is for everyone to tell us from what you have heard from the presenter's presentation, what do you think is the provisional diagnosis? What are the differential diagnoses from what the presenter has presented? What do you think are the differential diagnoses? Why do you think those are the differential diagnoses, and why not? What are the positive and negatives of each differential diagnosis? Year 3 medical student, I expect for you to give me at least 5 differential diagnoses. Okay, and then I want you to comment on the presentation. What do you think is good about the presentation? If you think it's good, if you think it's okay, tell us, tell the presenter, why do you think it is okay? This is good because this. If you think the presentation can be done better, tell the presenter, how do you think it should be better? Alright, clear? Boleh? Jelas? Clear ke?
Clear.
Alright, okay, I'll pass the session to the presenter. So who's presenting?
Assalamualaikum. I'm Fatihah Nadia binti Mahadi and I'll be presenting a case. Okay, I'll start first. Aisyah, 2 years and 4 months old, Malay girl, was admitted to Hoshas, Temeluk, with the history of bilateral ankle swelling and rashes for 3 days duration. History was obtained from her biological mother. The mother claimed her child was apparently well until 3 days prior to admission, when she developed bilateral ankle swelling with rashes. Mother noticed the swelling and rash when Aisyah who was playing and running with her siblings, suddenly stopped playing, walked abnormally and refused to move. The swelling was erythematous, warm to touch and painful. Regarding the rash, mother was unsure whether it was prior to the swelling or not. The rash was located on the dorsal aspect of the both feet. It was described as raised, reddish, well circumscribed, multiple small pinpoint size rash. Some rashes are irregular and bigger in size. The distance between each lesion was less than 1 cm. It was painful on touch but not associated with itchiness. No rashes were found at any other places of the body. Also, no flares of rash upon sunlight exposure. On the following day, the swelling and rash progressed up to the level of the mid-shin for the right leg. Aisyah also developed vomiting on the second and third day of illness. The vomiting was more than 5 times and amount about 1 cup each time. It was non-projectile, containing milk and food particles, but no bile or food was seen. Mother complained that a child started to have loss of appetite due to the vomiting. Normally, she would have about 7 ounces every 2 hours. It reduced to not more than 3 bottles, and Aisha was unable to finish her milk and refused feeding. The mother did not notice any weight loss. Urine output was reduced when she normally had more than had 3 times wet nappy per day, but prior to admission, she had not urinated. There was also history of constipation where her usual bowel habit was at 2 or 3 times per day, and it reduced to none during the course of illness. The mother was not worried about the constipation since she does not eat. However, she did not pass flatus for 3 days duration. The mother decided to bring her child to the ED of Horshas when Aisha looked tired and weak. She then was admitted to Pig's ward on third day of admission. On third day of admission, she had sudden onset of intermittent generalized abdominal pain. Mother was unsure of the aggravating and relieving factor. Aisha was crying each time and she also had abdominal distension. She did not pass a motion of latex. She was then referred to surgical department and was diagnosed with interception. She was further managed in HTAA Kuantan and ileostomy was done. Otherwise, there is no history of fever, contraction, no pallor or spontaneous gum bleeding, no easy bruising or epistaxis, no family history of bleeding disorder, no significant loss of weight or appetite prior to illness, no hematuria or crying while urinating. Mother also denied any conjunctivitis or palpable gland. Currently, Aisha is on her 33rd day of admission. And then on systemic review, apart from loss of appetite due to vomiting, there is no complaint of fever or loss of weight. No neck stiffness such as crying when lying, no ear discharge and ulcers, no bruises or head injury. There was no, on cardiovascular system, there was no history of shortness of breath, autopnea or PND. Respiratory system, no cough or runny nose or rapid breathing, hemoptysis or night sweat. On GI system, there were episodes of vomiting and abdominal pain, but no diarrhea, constipation. There was no diarrhea, parectal bleeding. The stool color was yellowish and brownish. On genitourinary system, no abnormalities such as frothy urine, hematuria, and changes in urine frequency. But she had oliguria. Musculoskeletal system, apart from joint pain, no weakness or bone pain noted. On past medical and surgical history, this is her first hospitalization and currently on 33rd day of admission with no non-medical illness, and she had not done any surgery before apart from had the ileostomy done. On birth history, antenatal history, the mother had anemia but required no admission or blood transfusion. She had attended all the antenatal screenings. No other abnormality was noted. No history of intrauterine infection or hypertension or GDM during the pregnancy. Intrapartum history, the patient was born full term via elective lower segment cesarean section due to previous cesarean scar with no complication. Her birth weight was 2.9 kilogram. It was uneventful. On nutritional history, she had mixed feeding since 1 month old. The mother did not remember accurately of the frequency and the duration of the breastfeeding. She began weaning at 7 months old with soft diet like rusky biscuit. Around 2 years old, she started on adult diet and is tolerating it well. Currently, she is on formula milk. It amounts about 7 to 8 ounces per feeding for every 2 hours, alternating with food. She also take adult diet with 3 regular meals per day, breakfast, lunch, and dinner, which consists a small bowl of rice or porridge, chicken, formula milk, and biscuit. She does not consume the vegetables. However, she has no known allergy to food. Her current weight is 10 kilograms. According to her mother, both bottles and teas are always boiled in hot water before use. The child has appropriate developmental milestone at her age, and on drug history, she is not on any medication and no non-drug or food allergy. Immunization was completed up to her age with no allergic reaction. On family history, her mother is 30 years old and her father's age is 33 years old. Aisha is the youngest out of 3 siblings. All family members are healthy and had no non-medical illness. Otherwise, there was no family history of bleeding disorder. It is a non-consanguineous marriage, no history of congenital anomaly, neurological disorder or malignancy running in the family. Personal and social history. She lived with her parents in a village house in Seberang Temerloh. It has adequate basic amenities, including water and electrical supply, with good ventilation. It is not a dengue-prone area and there was no rodent infestation. No smoker in family. Her mother is a full-time housewife while his father is a farmer. The total family income is below 1,000. Then they receive help from family members and from the government. The nearest health facility is about 5 minutes away. On physical examination, on general examination, the child was conscious, alert, and active. The child was pink, not septic looking, with no sign of respiratory distress. She has a normal body build. There was no dysmorphic features, no neurocutaneous stigmata, and no rashes. There was a branula intact. At both his right at his right dorsum hand, with no infusion, and the branula at left dorsum hand with an active IV infusion of normal saline. On peripheral examination, there was no clubbing, peripheral cyanosis, or palmar erythema. The periphery was warm with capillary refill time was less than 2 seconds. Skin turgidity was normal. There was no pallor, jaundice, or central cyanosis. There was no lymphadenopathy. On leg examination, there was no bilateral ankle swelling as it has resolved on the day of examination. However, there were rashes noted from the sole of the feet, knee, and back of her hand. The rashes were multiplied and the distance is less than 1 cm. It was reddish in color, size ranging from 2 mm to 5 mm. It was palpable with circumscribed border. It was also non-tender on touch and non-blanching. Some rashes are healing with bluish color at posterior thigh, behind the ear, and her arm. On vital sign, blood pressure were normal, heart rate normal with regular rhythm and good volume. Respiratory rate is normal. Temperature, she is febrile with SpO2 98%. On anthropometric measurement, her weight is 9.7 kilogram on third centile. Her weight is 85 centimeter between 10 and 25 centile. On systemic examination, on abdominal examination, on inspection, the abdomen was symmetric, not distended, and moved with respiration. There was a healing midline laparotomy scar measuring about 7 centimeter. It was a functioning stomach bag attached on the right iliac fossa with presence of sprout with two openings containing semi-solid greenish yellowish feculent. Umbilicus was centrally located and inverted. On palpation, the abdomen was soft and untender. Liver and spleen were not palpable. The kidney were not ballotable. On percussion, shifting downwards and fluid trill were negative. On auscultation, normal bowel sound was heard with no renal or aortic bruit. On respiratory examination, on inspection of the chest moved with respiration. There was no chest deformity and chest recession. No surgical scar or dilated vein was noted. On palpation, trachea was centrally located. Apex beak was felt. On palpation, trachea was centrally located. On auscultation, vesicular breath sound was heard on both lungs without any added sound such as rhonchi or crepitation. Tactile vocal parameters, percussion, and vocal resonance is not done on this patient. On cardiovascular examination, on inspection, there was no chest deformity, surgical scar, or visible pulsation. On palpation, the apex was felt for intercostal space at left mid-clavicular line with normal volume. There was no trill and parasternal heave. On auscultation, the first and second heart sound were heard at all area. No murmurs or added sound were heard. On CNS examination, child was actively moving her upper and lower limb. There was no neurocutaneous stigmata, no muscle wasting or fasciculation. The tone was normal. Power was at least 4/5 for both upper and lower limb. No clonus was noted. The reflex was normal and equal bilaterally for upper and lower limb. Babinski sign is downgrowing on both feet. On summary, Aisha, 2 years old, 2 years, 4 months old Malay girl who was born term with no developmental delay, presented with complaint of bilateral leg swelling and rashes with vomiting for 2 days duration. The swelling was tender, erythematous, non-pitting, and she was unable to ambulate freely. Vomiting was about 5 times with poor oral intake. She also had constipation and developed a sudden onset of abdominal pain and abdominal distension on the 3rd day of admission. Otherwise, it is not associated with fever or respiratory system. No bleeding tendencies were observed. There are not living in dengue-prone area, and no history of traveling or water activity. On physical examination, some rashes have resolved. Purpurate rashes are prominently distributed at the sole and the back of the leg. It was palpable, non-blanching, 2 to 5 millimeter in size. Multiple and distance between rash is less than 1 centimeter. That's all for...
Okay. All right. So what's gonna happen now is let's hear from your colleagues. So what do you think are the provisional diagnosis from Fatin's presentation, and what are your differential diagnosis, and then comment on Fatin's presentation. So I'll go from my the sequence on my screen here. The first will be Hafiz. Lepas Hafiz will be Naufal. Lepas Naufal will be Farha. Lepas Farha will have Ummil. Lepas Ummil will be Nur Elisha Karlina. And then after that will be Sharifah Nur Hayati. And then Izza Jamil, followed by Nick Zaid Zuhdi. And then last but not least will be Nur Lailatul Nazira. Okay. All right. Let's hear. Hafiz, what do you think is the provisional, differential, and then comment?
Um, I think my provisional diagnosis is cellulitis.
Okay, your provisional is cellulitis. Cellulitis, is that all? That's cellulitis?
Um, my provisional diagnosis might be bite insect.
Okay, so your your provisional is just cellulitis. Cellulitis, yeah.
Complicated with
Complicated with, yes. Does cellulitis explains all the problem the patient has?
no, complicated with complicated with
Okay, all right. Okay, give me your other differences, please.
okay. I'm thinking of bite insect, and maybe also um, eczema. Um, and it may be caused by autoimmune causes such as psoriasis.
Psoriasis. Why do you think it's psoriasis? Why and why not?
Because it has rashes that are up to windshield.
Where usually if you have psoriasis, where does the lesion typically is?
Sorry, doctor, I'm not sure. I'm just
Psoriasis mainly is over the scalp lah.
okay.
Lepas tu dia basically more of like a skin peeling of the skin. Macam tu that's the type of lesion. Okay. Okay, fine. Hafiz, I'm not going to trouble you much more. Okay, comment on her presentation. What do you think? What do you think is good, and how do you think she can improve on her presentation?
I think from the presentation, the presentation is good. I'm not sure what to comment.
But okay, why do you think it's good? Good. There must be a reason for it to be good.
Because I think she explained the symptoms very well. Describe the main complaint, and also rule out also other diagnosis also.
Okay, but then you struggle. You seem to struggle to suggest the provisional and differentials.
Yes,
Despite it being very clear for you. Okay, tak apa. Alright. Let's listen to the next. So, Naufal, ready? Shoot.
I think the provisional diagnosis is inoxinolene purpura because there is rash, and also bilateral ankle swelling maybe indicate renal involvement in this disease, and also constipation, vomiting may indicate GI involvement in HSP.
Okay.
And the rest
What type of renal involvement and what type of GI involvement you are thinking of?
involvement.
I agree with you. There is probably problem with renal involvement, something. It can be GI, but what is that involvement? What type of involvement?
Type of involvement. ischemia, there is vasculitis, and then there is ischemia at the organ, and
Okay,
cause
if you have HSP, what is the if you have HSP and then involve the kidney, what can happen to your kidney in HSP?
nephritis.
Nephritis, yeah, that's what I'm trying to get. So nephritis or nephropathy, yeah. Okay, the other one, kalau GI
Ischemia.
before ischemia. The presenter already mentioned the diagnosis even.
Intussusception.
Okay, yes, intussusception. So intussusception is a complication of HSP. Okay, all right, fine. Differentials.
Maybe SLE.
Okay, why and why not?
Because there is SLE because there is some manifestation like rash, and also the renal involvement, but there is no in SLE. There is no involvement with the sunlight, no exposure to the sunlight.
Okay, what is that problem? Sunlight problem with SLE. What is that? What do you call that?
Photosensitivity.
Photophobia.
Yeah, okay.
Okay, all right. You guys should third year banyak sepatutnya in terms of teori ni banyak lagi ya. Okay, alright, lagi.
Differential, ada differential. Maybe dengue fever.
Okay.
Because there is rash and also abdominal pain, maybe warning sign of dengue fever. And also is it swelling indicate any plasma leakage?
I'm not sure. Is it just me ke? Start. Okay. Okay, what else other than dengue? I want 5, isn't it?
Okay. Heart failure because of the bilateral ankle swelling. Heart failure.
You're thinking of heart failure, okay? Fine. Why and why not?
Because she had bilateral ankle swelling, but I cannot see any other manifestation that indicate heart failure like orthopnea, PND, and also dyspnea.
Alright. Okay, good. Naufal, tak apa. So, comment on her presentation. So, you give 4 differential kan? Tak cukup lagi sepatutnya. Tapi tak apa, it's okay. Comment on her presentation.
I think she's good. The presentation is well organized. But I think it is so fast. I cannot view well lah. I cannot catch the point.
Okay, alright. You would like the points to be given in a slower way lah. Okay, alright. Okay. Anything else?
I think that's all.
Okay, let's get to the next. Farha. Provisional differential comment.
My provisional diagnosis would be HSP because it presented with the classical HSP presentation such as rash, which is palpable purpura and usually symmetrical, which in this patient, the right and left foot. And also it presented with the abdominal pain. And in HSP, usually the commonest complication is interception. So in this patient, the presentation, patient had interception because it presented with vomiting and also no passing of flatus or bowel for the past 3 days.
So what are those symptoms that you were saying?
It suggests
What do you call this? So what has happened? So there's interception. Then what has happened? What is that complication called? Intestinal obstruction.
IO.
So intestinal obstruction. Okay. All right. Okay. Fine.
But in this presentation, I failed to hear the other presentation of HSP, such as arthritis or arthralgia. So the presenter.
Okay. Wait. Did the presenter mention that there is joint swelling, joint pain?
Yes.
Ada tak? Fatin ada, Fatin?
Ada.
Ada. Fatin ada cakap kan? Itulah Fatin.
Oh, tak dengar.
Human kan, they never listen to you 100%. This is I need to emphasize to the ladies here. Kan, no one listens to you 100%. No one. Oh, lucky of course lah. Kamu tak dengar pun. But so as human being, no one listens to you 100%. We are human beings, we are selective listener. We only listen to things that we want to listen. No one listens to you 100%. Okay? Alright, so Fatin dah berbuih cakap joint pain, joint swelling. Several times she repeated pun. Not just once
I'm sorry.
Okay, alright. Next, apa lagi Farah?
Besides the DDX would be can it be chickenpox? Because of the presentation such as the rash, but the classical rash of chickenpox is usually begins at the truncle and then it is itchy, but in this patient it in the feet and not itchy, and also associated with leg edema. Also in this patient, she doesn't have any headache, malaise, cough or coryza. But some patient with chickenpox also complain with abdominal pain, seems like in this patient. Chickenpox.
Okay, lagi? Five. I want 5 differential.
Other would be Kawasaki disease, but this patient does not presented with fever. But fever tak ada, conjunctivitis tak ada, mucosal changes tak ada. But she had changes in extremities, which is the edema and rash on the feet. But the characteristic of rash in Kawasaki is not like this patient. Usually it is non-vesicular. So I suggest Kawasaki disease because of the changes in extremities and rash in the lip. And other differential diagnosis would be post-strep glomerulonephritis because the presentation with bilateral leg swelling may suggest nephrotic syndrome. But the patient does not have any prior history of URTI. And then the rash does not compatible with the diagnosis. Other okay. The DDX will be hand, foot and mouth disease because of the rash. But in HFMD, there have no bilateral, there's no leg swelling. So that's will not suggest it.
Okay, how would you describe the rash in HFMD?
Usually, I'm not sure.
Sometimes it starts with small vesicles. Could be a vesicular type of rash. Okay, all right. Farha, comment on Fatin's presentation.
Fatin present very well. She explained about the presenting illness very well according to the what we should do. And then the medical history also very well. She include all the things that we want to we need to ask in this presentation. So I think she do it very well.
Okay. Alright. Before we go to the next, siapa sepatutnya next? Next sepatutnya Umil. Okay. Alright. Before we go to the next, why do you think we do this? Why do you think if you have long case sessions with me, this is how we're going to do it? Why? Anyone has any idea?
So that we actively listen to the presenter, and also in examination we need to come out with the provisional diagnosis and the differential diagnosis.
Okay, macam ni. Okay, the reason being because you all are the same batch. You all are the same batch. Theoretically, you all should have around the same level of medical knowledge. You all would have around the same level of clinical judgment and clinical acumen. So in that sense, if your presentation is good enough, if your presentation is focused enough, your listener should be able to think, oh, the presenter is trying to guide us towards this provisional diagnosis. Faham? Kalau semua orang, bila lepas dengar your presentation, semua orang tak sure, provisional ni ke mana ni? Tak tahu. So probably your presentation tu, hala tuju dia tak tahu ke mana. Kan? Hala tuju dia tak tahu ke mana. So your listener semua tak tahu, ni nak target ke mana ni? What diagnosis nak target ni? Dia tak tahu. Faham? So it shows that your presentation is haywire. Sebab tak tahu hala tuju dia ke mana. Tak tahu what is the target, what is the objective, what is the focus of the presentation. So if the presentation is a good presentation, your listeners semua boleh dengar, okay, oh, she's trying to focus on this diagnosis. Semua orang boleh tahu. That's one thing. And then, if your a good presentation should be robust enough. Kena ada cover adequate differential diagnosis. Kena cover at least 5 differential diagnosis, the pros of that differential diagnosis and the negatives of that differential diagnosis. So, if your presentation is good enough, your listener of your same peer, of those people who has around the same level of medical knowledge, of clinical acumen, clinical judgment, they should already know, oh, okay, these are the differentials that the presenter is trying to rule out. Kan, kena ada at least 5 differential diagnoses. So this is the reason why. Kalau after you present, and then your friends, your peers, struggle nak bagi differential diagnosis. Tak tahu, alamak, apa differential lagi? Boleh bagi 1, boleh bagi 2. Semua orang bagi differential lain-lain. Semua orang differential yang mungkin dia plug daripada dia punya knowledge je. Bukan yang dia dapat daripada your presentation. So it shows that your presentation is very narrow presentation. Your presentation doesn't cover enough differential diagnosis. So this is not a robust enough presentation. So and then it assess your friends as well. It assess your listeners as well. Your listeners tahu tak what are the differential that the presenter is trying to assess and trying to present. So it covers both. We are trying to assess, what I'm trying to do is I'm assessing the presenter and I'm assessing you all as well. Okay, faham? So when you hear the presentation, you should know, okay, these are the differential that the presenter is trying to rule out. Okay, all right, it's not just that. A presentation, okay, you can never ask a proper question without you knowing what are the provisional, what are the differential, because you tak, okay, bila you club patient, kan, you tak boleh just bagi open-ended blind. Okay, so mak, kenapa datang hospital, sakit apa? Okay, you start with that, tapi without you knowing what are your provisional and what are the differential diagnosis, you will never ask the appropriate question. But sometimes the other time you nak kena bagi targeted, open-ended but targeted open-ended question. Sometimes you nak kena tanya juga yes and no punya question, sakit ke? So sometimes there may be a very focus and targeted questioning masa you clerking. And you can only ask those questions bila you tahu what is the provisional and what are the differentials. Kalau you tak tahu, you can never ask the appropriate question and you can never examine properly as well, because examination, especially in exam settings, you don't have enough time to actually examine everything. So it must be a targeted type of examination. Okay, all right. And the next thing before we go to Umil, what I want to emphasize is, what are the objectives of presenting a case? Bila kita Fatin is presenting a case next week, nanti every day akan ada student yang present case kan. As doctors, you all semua nak jadi doktor kan? Tak ada orang nak jadi insurance agent ke apa, tak ada kan? Adakah ada? Kan? Kita semua nak jadi doktor. So and as doctors, you'll be presenting cases every day, your whole life. Kan? Whatever type of doctor you are going to be presenting cases. Okay. So, what are the objectives of presenting a case? Anyone know? What is the purpose when we present a case? Kenapa kita buat, student kena buat long case presentation ni? What is the objectives? Ada 4 objectives. When you present a case, there are 4 objectives that you need to cover. Anyone has any idea?
Promote differential diagnosis. And promote
Okay, the first objective of any presentation is to sell, is to focus, to get to your provisional diagnosis. Your case presentation should highlight, should try and sell, should focus on your provisional diagnosis. So those people listening to your presentation should understand. So this is the focus. This is the star of the presentation. This diagnosis is the focus. You are trying to sell, you're trying to get, you're trying to focus, you're trying to highlight this provisional diagnosis. So the first objective is to focus, to get, to sell your provisional diagnosis. That's the first objective. Second objective is to rule out your differential diagnosis. So a good presentation should rule out at least 5 differential diagnoses. At third year level, I expect you to rule out at least 5 differential diagnoses. Maknanya your presentation, based on the chief complaint, based on the HOPI apa semua, you need to rule out inside the HOPI ke, inside your systemic review ke apa benda ke, you need to rule out 5 differential diagnoses. You need to highlight what are the 5 potential differential, what are the positives and what are the negatives of each differential diagnosis. Faham? So that is the second objective. Okay, alright. What is the third objective of any case presentation?
Look for complication of disease.
Yes, look for complications of the disease, because all disease, every disease in this whole wide world has its own complication. Nothing do not have any complication. Nothing. Everything has its own complication. Everything. Duduk atas jalan raya ada complication dia. Pakai mask ada complication dia. Everything has its own complication. Nothing in this world that does not have any complication. So, as a good doctor, you need to look for the possible complications of the disease. So, look for the complications of the disease. Okay, alright. That is the third objective. What is the fourth objective?
Look for complication of treatment.
Yes, look for complications of treatment because everything that you do to the patient has its own complications as well. Even not doing anything has its own complication. Kan? Kalau masuk 55 hari dah and then tak buat apa-apa, that has its own complication. So a good presentation should cover as well what are the potential complications of the treatment. Treatment to not just treatment done by the doctors and nurses, it can be treatment done by the parents at home. Parents buat apa? Parents buat apa dan parents tidak buat apa. So all those things has its own complication. So you need to look for those. Especially like in Fatin's punya presentation, this is already day 55, isn't it, of admission. So many things has been done to the patient. So many things has been performed. So many things has happened to the patient. So what are the complications? So your presentation should cover all those things. Faham? Clear? So this is the reason why I'm doing this, because we need to assess. We are assessing you, we are assessing the presenter as well. Okay, alright, clear? Boleh? Faham? Jelas? Okay, let's go to the next. Ummil. Lepas Ummil, Nur Elisha Karlina. Lepas itu Sharifah Nohayati, and then Iza, Nik Zaid Zuhdi, and then ada seorang tak ada? Hilang dah seorang. Siapa seorang lagi tadi? Tak ada seorang lagi. Tak apalah, fine. Let's go. Ummil. Shoot.
Okay. For provisional diagnosis, would be HSP because of the because the patient present with symptom of glomerulonephritis, which is a bilateral ankle swelling, and then and patient also has complication from the HSP, which is intersubception. My differential diagnosis, the first one would be Kawasaki disease because the presence of edema, presence of
Hello?
edema. But this patient does not have fever, and also the rash is not vesicular rash. The second differential diagnosis is nephritic syndrome secondary to SLE. The reason why I suggest this is because SLE is commonly occur in girl and present with bilateral ankle swelling. However, this patient does and also the rash is flare upon sunlight. And the third one is post glomerulonephritis because of the presence of the bilateral ankle swelling and also rashes. However, this is less likely because of the other symptoms such as hematuria. There is no symptom. Then the fourth sign is HFMD. But this patient in HFMD, the rash should be vesicular rash and no edema. And the last differential diagnosis, I thought of cardiac problem. However, patient not have. And okay, that's it for my differential diagnosis. So my comment on Fatin presentation. She present very well. She present in a structural way. We can conclude in what patient was diagnosed with. But there is some part that Fatih present a bit faster when it comes to the important part. So I missed that part lah. And that's all.
Okay, good. So important part should be slower and less important can be a bit faster. Okay, that's fine. Okay, next, Nur Elisha.
Okay, Bismillah. My provisional diagnosis is HSP because of the age of the patient. Usually HSP is common in 2 to 10 years old. And this patient, she fulfill all the 4 tetrad, which involve the skin, palpable rash. And second one is she has arthritis, and also arthritis. Third, GI manifestation with the abdominal pain, IO with constipation and flatus, and history of intussusception. And the last one, she also have renal manifestation, might be complicated with a nephritic syndrome. That's why she's also presented with bilateral ankle swelling. For the second differential diagnosis is SLE. She has positive finding of rash, arthritis, and abdominal pain. Also, she might also be presented with complication of nephrotic syndrome due to bilateral ankle swelling. However, the negative significant is she does not have fever, liver adenopathy, or significant weight loss. My third differential diagnosis is Kawasaki disease with positive findings of rash, arthritis, and the age of the patient, which is Kawasaki, is more common in a patient at the age of 1 to 4 years old. However, the patient does not present with fever, conjunctival injection, red or dry lips, and no liver adenopathy. And my fourth differential is rheumatic fever with the positive findings of rash, non-pruritic, and then arthritis. However, there's no history of recent group A beta hemolytic infection, and no cardiac involvement, no subcutaneous nodule, no chorea, and she's afebrile. And for rheumatic, usually it common in children at the age of 5 to 15 years old. And my last differential is juvenile idiopathic arthritis with a positive findings of non-pruritic rash, arthritis. However, the patient does not presented with fever and no liver adenopathy.
Okay, all right. Comment. Yes.
For the presentation, I think overall the presentation is good because she covers well the history taking and the physical examination, and ending well with a good summary. I think in my opinion, she's a little bit faster, as I cannot catch up significant negative findings.
Okay, all right. Let's hear the next. Next will be Sharifah Nurhayati. So tell us, what do you think is the provisional, differential, and comment?
Okay. As for me, the provisional diagnosis is HSE because the patient comes with the rash at the lower limb. The rash is non-bleaching and it was tender, and she has leg edema, joint pain, abdominal pain, and symptom of bowel obstruction. And also she has nausea and vomiting. Points against none. The differential diagnosis is SLE because of the presence of the rash. Leg edema might be due to nephrotic syndrome, nausea and vomiting, abdominal pain, also joint pain. However, the patient does not have any rash at other side, such as malar rash, and she has no fever, no history of infection. The next one is the immune thrombocytopenic purpura, ITP, because of the rash.
However, in ITP, usually there is no leg swelling, no joint pain, no history of infection. The patient has no history of infection, and the patient has no bleeding tendency. The next one is the acute hemorrhagic edema of the infancy, because the leg swelling, because of the presence of the rash, the edema tender. The leg swelling is a tender. There is a joint pain. Points against the rash is purpuric, not ecchymosis. Patient has no
Acute, what again the diagnosis you were saying? Acute hemorrhagic?
acute hemorrhagic edema of infancy.
Acute hemorrhagic edema of infancy. Acute hemorrhagic edema of infancy. I'm not that familiar with that. Are you sure? Where do you get that?
From the same textbook.
Okay, that's very rare. Okay, yes. Okay, fine. It's just that I'm not familiar with it. It's very, very rare. Okay, fine. Benign type of leukocytoclastic vasculitis. Okay, fine. All right. Okay, good. A very rare differential. Nice. Okay, what else?
The next one is the angioedema associated with urticaria. Because of the abdominal pain might be due to the bowel angioedema, leg swelling, and the onset of the rash is acute, is abrupt. So the points against is that it does not resolve spontaneously, and also there is no history of allergy. And the last one is the meningosemia without meningitis. Because of the rash, abdominal pain, and also vomiting. However, the patient does not have fever, and also there is no neck stiffness.
Okay.
For the comment on the presentation, I think the presentation is good. Is well, dia macam organized. But from the past medical surgical history, I think I want to know more further about the surgical, about the operation that has been done to correct the intersection. Is there any complication, or if the bowel obstruction is resolved, or if there's any complication lah. And then
All right. Okay. Lagi? Dah.
That's
done.
All.
Okay. All right. Good discussion. Let's hear the next. Iza, and then Nik Zaid.
Okay. My provisional diagnosis will be HSP because the presence of bilateral ankle swelling as a complications of nephropathy. And then a patient also presented with rash, which is palpable purpura rash. And then she had GI complication in insusception, and she also presented with abdominal pain. And then it also associated with vomiting and arthritis. So my differential diagnosis, the first one will be SLE because the patient presented with rash, but however in SLE there is a malar rash and photosensitivity which absent in this patient. And then
in SLE, what are the type of rash?
Malar rash.
Ataupun is it only malar rash?
No.
Discoid rash.
Discoid.
Yes, it can be discoid rash. Okay. All right.
And then a patient also presented with GI symptoms that also present in SLE, such as nausea and vomiting, abdominal pain, but the patient complained, but there's no diarrhea in this patient, which can exclude SLE. Um, and and there's no renal presentation such as hematuria or proteinuria, and there's no neuropsychiatric symptoms in this patient.
Okay.
For third differential diagnosis is Kawasaki disease because of presence of rash. But however, in Kawasaki disease, the presentation of rash is macular rash, especially on the trunk and genital area, which absent in this patient. And then why I come up with this diagnosis, because it is commonly affect 1 to 4 years old children. But however, I will exclude this diagnosis because the absence of fever, red or dry lips, or no lymphadenopathy. And then next differential diagnosis is acute rheumatic fever due to presence of arthritis, which is usually polyarthritis, but I can exclude it due to the absence of chorea, subcutaneous nodules, carditis, and also fever. And then lastly, the differential diagnosis is IBD because the patient presented with abdominal pain. But however, abdominal pain and also weight loss, but there's no diarrhea. And last but not least, juvenile idiopathic arthritis (JIA), but this one is chronic arthritis. So since it is diagnosis of exclusion, so will be my last differential diagnosis lah, because there's several criteria of this disease to jump to say that this is the disease, which is there is a persistent joint swelling, more than 6 weeks of duration, and it is commonly affect for people less than 16 years old. But in this disease, there is a joint swelling, pain, stiffness, and also warmth, which presented in this patient, loss of weight, and also present with rash. But however, there's no muscle atrophy, weakness, or serositis in this patient. For the comment for this presenter, she did present. She did present very good and very systematically. But however, there's some important points that I cannot catch because terlalu laju. I think that's all.
Okay.
Overall, it's
All
very
right.
good.
All right. Okay. Next, we have two more. Nik Zaid and then Nur Lailatul Nazira. Okay. All right. Zaid.
Okay. Assalamualaikum. So my provisional diagnosis is HSP because of the presence of rash at the lower limb, and then the symptoms of the GI symptom, the interception, which is the common complication of HSP, and then the ankle swelling due to the complication of HSP at the kidney. And then so the GI also explain the vomiting and then the abdominal pain. Then for my differential diagnosis, first is meningococcal disease because of the presence of rash. But in meningococcal disease, the rash is petechiae rash. Then there's no symptom of meningitis and there's no fever. Then my second provisional diagnosis is differential diagnosis is ITP because of presence of rash. But in ITP, usually a patient will have mucosal bleeding, but in this patient, there's no mucosal bleeding and there's no hematuria. Then my third differential diagnosis is septic arthritis because of the joint pain. But then this patient doesn't have any history of any infection and no fever. Fourth is JIA, juvenile idiopathic arthritis. So this patient has non-paralytic rash and joint pain, but then again, this patient has no fever. And then GIA usually presents with morning stiffness that improve in the day. Then my last differential diagnosis is SLE, because of the presence of rash and then the presence of the ankle swelling, which is explained by the nephrotic syndrome in SLE. But then due to the absence of the rash in other parts of the body, because HLE, usually the rash will develop in the face and other parts. So that excludes SLE.
So the rash is usually more generalized, kan? Okay.
Generalized
Alright,
rash.
good. Okay.
Then
Alright, so comment.
my comment to the presentation, good, systematic, all of the relevant positive and negative sign is well mentioned. But then maybe because I cannot see the presenter's face, but then I think the presenter can improve in terms of her intonation, maybe intonation and the flow to look more convincing. But then other is good. That's all from me.
Alright. Okay, good discussion. Okay, the last. Let's hear to Nurlailatul Nazira. Yes, should. Hello, mana Nurlailatul Nazira? Ada tak ni? Nurlailatul ni?
Maybe she had some
internet problem.
Tak ada.
We've been losing her. Okay, fine lah. Tak apa. Okay, alright. So we've listened to all your provisional and differential. Mainly provisional sounds the same. Differential, everyone has different differential. That's fine. That's okay. Okay. Let's hear from the presenter. So, Fatin, what is your provisional and what are your differential diagnosis?
Okay, for the provisional diagnosis would be the HSP complicated with interception, because this patient presented with palpable purpura, and then she had manifestation, which is arthritis, and then she had DGI manifestation, which is the abdominal pain, and might be the renal manifestation, which is glomerulonephritis, causing the patient to have edema. And then the common complication for this HSP would be the interception, where this patient also had this interception. And then for the differential diagnosis would be the first.
Wait, Fatin. Okay. So Fatin, wait, can you hear me?
Yeah, yes.
Okay. So your provisional is
HSP
complicated with
interception.
Why you say it's interception?
Because patient presented with IO symptom, which are vomiting, and then abdominal pain, abdominal distension, and then another one is unable to pass flat test, which is kind of absolute constipation. And then
small IO. Okay, fine. So
and then
how do we usually treat interception?
Actually, for to confirm it is interception is actually the abdominal X-ray.
Okay. All right.
Yes. Where this patient had the abdominal X-ray, I think so. But
I'm not sure. Is it my connection to Fatin? Dia macam pecah-pecah. Is it from my side ke? Can everyone hear Fatin very clearly?
Yes.
Yes.
Oh, probably it's on my side then. Okay, all right, Fatin. So
yes.
the treatment for intersection. Usually before, so this patient underwent colostomy, isn't it? Stoma formation. Kan?
Yes.
So
Yes.
is it usually the first line of treatment for interception? Stoma formation?
Oh, I'm not sure.
No, usually it's not the first line of treatment, isn't it, for interception? So usually apa yang kita akan try buat dulu?
Doktor?
Dengar tak? Dengar tak? Usually what will we do first before we go for colostomy?
Surgical ke doktor? Surgically betulkan balik dia punya interception. Ataupun
Okay, so
ada
that,
setting saya baca taruh udara daripada anus.
okay, so there are other maneuvers first. So in your patient, why do you think they went straight for colostomy ke? Do they try something else first? So because sometimes dia boleh reduce radiologically kan?
Yeah. But he just said about the ileostomy, not other treatment.
So okay, so
I'm not sure whether she had any treatment before.
So one thing that you need to inquire as a doctor, you need to ask why went straight away for ileostomy. Usually this is because they fail to reduce the interception using radiological procedure, kan? Sometimes dia boleh guna contrast reduction untuk interception. Okay, alright, fine. Is that all the complication that this patient has? Any other complications? Your friends have been mentioning another complication. Do you agree with that? Several of your friends has been mentioning another complication in HSP. Do you agree with that?
Pardon, doctor?
So I'm saying
Pardon,
your
doctor?
friends has been mentioning about another complication in HSP. Do you agree with them?
Doctor?
Tak dengar?
Sorry, doctor, we couldn't hear doctor clearly, no.
Saya dengar je.
Alamak, macam mana
Doktor tanya ada complication sebab tadi ada yang state ada complication. Lepas tu doktor tanya setuju ataupun tak. Dengar ke Fatin?
Sorry, doktor, I couldn't tak dengar langsung.
Fatin, several your punya kawan-kawan ni ada mention your patient ada another complication of HSP. Your friend kata patient ni ada nephropathy lah, nephritis kan? So do you agree with them?
Yes.
Do you agree or you don't agree?
I agree. But in terms of that manifestation, but if we say that this patient had glomerulonephritis, this patient only had the renal symptom only oliguria, but there's no hematuria, there's no proteinuria. So I was like, might be, but the manifestation would be not really supported that complication.
Okay, so your patient only has bilateral ankle edema and also some oliguria, is it? There's no hematuria. Hello?
Yes.
Can you hear me? There's no hematuria. There's no proteinuria.
No proteinuria.
Okay, there's no periorbital puffiness.
No.
So basically nephritis not entirely sure. We need to investigate, isn't it? Okay. All right.
Yes, yes.
Good. How? What is the typical distribution in HSP? Typical distribution of the rash in HSP?
Typical. I'm not sure regarding whether it is more common at the flank, but for in terms of its characteristic would be it is palpable and it is not itchy.
So it's a palpable purpura. It's
Yes.
not itchy.
And it is non-itchy.
It's non-bunching, kan? And then it will be different ages
Yes,
lah.
yes.
The different ages. And then the distribution usually is more on the extensor surfaces. Usually more common
Yes,
on the
it is common
extensor
in dependent
surfaces.
area like the buttocks and lower extremities.
Okay. All right. Differentials. What are your differentials?
My first differential diagnosis would be the ITP, which is immune thrombocytopenic purpura, where points for would be because this patient had purpuric rash, and then the peak for the ITP to occur would be between 2 to 4 years old, which mesh with this patient. But in terms of against point would be she did not any bleeding tendency, and then she did not any easy bruising, and then there's no epistaxis like bleeding tendency. And then second differential diagnosis would be SLE, where this patient have the purpuric rash. Patient had the abdominal pain, joint pain, and then but the points against would be there is no other features of SLE like the generalized kind of rash, and then no the classical rash in this patient like malar rash, discoid rash, and then this patient does not have any fever. And then the third differential diagnosis would be hemophilia, since this patient had the rash, but points against since this patient did not any family history of bleeding disorder. And then the fourth differential diagnosis would be the meningo.
Fatin. What is the
Yeah,
gender
yeah,
of this patient? What is the gender of the patient? What is the gender of the patient?
Girl.
Female.
Girl.
So is hemophilia common in female?
It is less common in female.
Okay. How is it heredited? How? Hemophilia.
X-linked.
How is the hereditary pattern of hemophilia? How is it inherited?
It is
Anyone wants to help? Inheritance pattern in hemophilia?
X-linked recessive.
Huh?
Recessive X-linked.
Yes, it's X-linked. Okay. All right. So it's very uncommon to be in female, kan? Okay. All right. Okay. What else?
Yes.
What are the differentials?
My differential would be meningosemia septicemia. Because this patient had the purpuric rash, the ankle swelling, the abdominal pain, but there's no fever. Meanwhile, the classic feature for this disease would be the fever and non-blanching rash, but this patient did not have any fever. And my last differential diagnosis would be GIA, which involved the inflammation of the synovium, where this patient had the joint swelling, pain, but it is, as Iza said before, it is more chronic pattern. It is a chronic disease where it involves actually more than 6 months duration. And indeed, GIE is an disease of exclusion.
Okay. All right. Anything else? Anything else? Is that enough? Differential? Berapa? 5 dah bagi. Okay, fine. 5 boleh. Okay. Could it be something in the line of cellulitis? Complicated with septic areas? Can it be around in the line of that?
But the rash is not painful. In cellulitis, it is painful.
Okay, yes, very good, very good. And then the surrounding skin, but you did say it is erythematous, kan? Okay, fine. So tell us, usually what is the natural history of Henoch-Online purpura, HSP? What is the natural history?
Actually, okay, in terms of the etiology, the exact etiology of the HSP actually unknown, but it's be multifactorial, which involve the genetic predisposition, and then infection. Another one would be involvement of the drugs, which the exposure to the antigen, to the drugs, the genetic predisposition, causing the IgA immune complex to be the production of IgA immune complex would be increased, which this complex we deposit in any parts of the organ, which then this complex we deposit at the vessels, causing the inflammation of the vessels, lead to vasculitis. And then if the in terms of the clinical features, it usually presented if there is present, I mean like if the vessel involved is the vessel that supply the intestine, it can cause ischemia, causing the patient to have abdominal pain. And then this patient can have kidney manifestation, like causing glomerulonephritis. But in this patient, I think it is no. And indeed, it can cause even renal failure and microscopic hematuria. As for this patient, she had manifestation would be the purpuric rash, and which it is a palpable rash. And there is also the joint involvement, which is arthritis, which can limit the movement of a person. And how we can know exactly, like in this patient, she refused, her mother noticed that this patient refused to move and even cry when she want to ambulate. Might be suggestive of the arthritis. Indeed, there is erythematous, and then there is swelling of the arthritis at the joint. And
Okay. Okay, good. I think overall, your presentation is quite okay. You've covered almost all, but I think the differential wise, so for HSP, I think you have mentioned quite clear lah. Cuma a few things that I wanted to comment. Okay, you did mention you clerk, you bukan you clerk lah ni, you dapat dari case write up kan. So you did mention the history is you obtain the history at the day 55 of admission. Okay?
day 33.
Day 36. Okay, day 36 of admission. But the other thing is whether the examination is done on the same day, maknanya day 36 of admission ke tak. To one thing. The other thing is one thing you from the presentation, you haven't mentioned enough about the complications of the. Okay, you mentioned complication of the disease, but we would like to know more about the complications of the treatment as well. Because what are among the treatments for interception in HSP? Sometimes we may give NSAID, ibuprofen, kan? So and whether that was given or not, why was it not given? And you know, ibuprofen has its own complications as well. So complications of the treatment. So the patient has undergone surgery. What are the complications of the surgery? So benda tu pun kita nak dapat more information. Okay, all right. The other thing is, I think my only concern with your presentation is the complications and also the differentials. I think it is not clear enough. So you did mention 5 differential, but in your presentation, the differentials are not actually dwells enough in your presentation. But otherwise, generally it's okay, it's acceptable. Okay, good. I think we have gone 1.5 hours lebih kurang. That should be okay lah. All right. Any question? Any question to the examiner or to me before we start?
I have a question.
Yes.
From my reading, it said that HSP is more common in the winter and spring and unusual in summer month. Why?
There's no clear reason. We don't actually know. It's just a observation that people notice. The thing is, we don't actually understand fully why it happens. People say that probably it begins with a viral infection. So sometimes 1 week before the onset of the lesions and things, sometimes the patient may start with a mild viral infection, and then lepas tu after 1 week baru start ada those lesions. But we don't actually know, we don't actually understand fully why. Okay, all right. Anything else?
Doctor.
Yep.
For this presentation, since we already have 5 differential diagnoses in our head, can? So is it important when presenting the case? So we have to include all the the presentation in the masa nak present tu. To just macam nak exclude the diagnosis ke, macam certain some part of the clinical features. So the other parts tu kita masa bincang dengan doktor.
I think what you actually need is from your presentation itself. It must be clear enough. It must be clear enough. But you decide how deep you're going to go. How deep you want to present is up to you. But it must be clear enough. It must be clear enough. Maknanya when you listen to the presentation, you can know what are the differential and what are the negative points for that differential. Okay. One more thing I wanted to mention to Fatih. Okay, I'm not happy with your summary sebenarnya. Sebab okay, your summary is very important. A good summary, if you have a good summary, it shows that you actually understand the disease. You know what are the important positives and what are the important negatives. You punya summary tadi banyak benda-benda yang tak important pun. Benda-benda yang doesn't have any value to your provisional diagnosis to put in your summary. So summary itu kena potong-potong banyak benda lagi. Okay. Alright. I think that's all lah. It's already 1.5 hours. I have another session with your chief here after this. Okay. Alright. Clear. Any burning question? Tak ada. Okay. Okay. Let's end our session with tasbih kafarah and surah. Okay. Assalamualaikum.
Waalaikumsalam. Thank you, Doktor.
Thank you, Doktor.